Welcome, everybody, to Pediatric Grand Rounds. People are still trickling in, I'm sure, but we're going to get started because, it's the noon hour on a Thursday and people have places to go, and we want to make sure that we get to hear everything that our speaker today has to tell us about. We're going to start with a brief land acknowledgement to acknowledge the land of the Ramaytush Ohlone people, who are the traditional custodians of this land. And we do this land acknowledgement, hopefully not just as a tokenistic kind of like that's what we do these days, but to really also say this is why we're here, right? To honor the tradition of building community and strengthening our relationships across different communities. And so this is actually the Grand Rounds today is a little bit in that spirit, in the sense that we have a professor, assistant professor from the Division of Pediatric Dermatology come speak to us. And pediatric dermatology is one of those fields that sits in both dermatology and pediatrics. And having colleagues and friends in that division, they always remind me, like, we are pediatricians too, we count too, we need to get together more. So it was really exciting actually that we managed to get a speaker from that group here, because building those bridges I think is incredibly important. And our speaker today is Dr. Sarah Coates. Dr. Coates is an assistant clinical professor of dermatology here at UCSF. She did her undergraduate studies at the University of Texas at Austin and Weill Cornell Medical College, and completed her dermatology and pediatric dermatology training here at UCSF. She's currently an HIV dermatologist and a board-certified pediatric dermatologist, and serves as the assistant fellowship director for the fellowship in pediatric dermatology here at UCSF. She became passionate about social drivers of health as a result of her upbringing in a small town in West Texas and her extensive experience working in East Africa. Her clinical and research foci include medical education, pediatric dermatology, HIV-associated inflammatory and malignant skin diseases, the impact of social determinants on dermatological health, and the effects of climate change on dermatological diseases. So, just a few very kind of minor topics that have no real importance in today's life. Oh, they do. So I'm really excited to hear about this. We were just joking before the talk started that I always do a pretend know about skin diseases, macular papular rash, that is blanching, non-blanching, but I really don't know that much about it anymore. So I certainly don't know a lot about social and structural drivers of health in pediatric dermatology. So I'm really glad to welcome Dr. Coates to the podium.
Thank you. Thank you so much for that. It is really my honor to be here. I really value this community, and I appreciate your introduction. And I'm excited to be able to talk about this for the first time with you guys. I have no conflicts. So there's a couple of things I want to talk about to kind of lay the land. First of all, I want to acknowledge that pediatrics as a specialty has done probably the brunt of work in terms of our understanding of social determinants and adverse childhood experiences and how they affect health. And what you might not know is that this is very new in the House of Dermatology in terms of our even thinking about this in terms of formal curriculum, and are talking about this in clinic with our patients and with our trainees. And so this is very new to us, and I just want to acknowledge, I know it's not new to you. It's really important to me that diverse skin tones be represented when we're talking about dermatology, but this is really not a clinical talk. So you'll see me kind of flash up a couple skin diseases to show you examples of the struggles people are facing, but it's really not about managing those diseases. This is about how the data shows that even though we're not talking about this a lot in dermatology yet in a formal way, there's actually already quite a bit of data to show how these things are affecting our patients. And so a few things that we'll talk about today, some of which I won't spend a lot of time elaborating on because of my audience, but we'll talk about social and structural drivers of health and adverse childhood experiences, defining those terms and giving some examples. I'll go over what the data shows in terms of which skin diseases are particularly strong in terms of social drivers, go over some really practical tips that you can think about in clinic, or that I'm encouraging our trainees to think about as we deal with low health literacy and making complicated care plans, talk about some of the over-the-counter products that we can use and how you can think about cost for some of your patients. thinking about how we use telehealth to address some of these challenges, and then finally asking, should dermatologists be screening for this the way that some pediatricians do? And if so, what is a practical way to do that in a busy clinic? So I wrote this yesterday. I think this slide, not the whole talk. This I could have chosen so many different variables here, but it's really helpful to think about who we're trying to take better care of. So your patient's 8 years old. He comes in to you for his initial evaluation of eczema. It's very widespread. His mom and his younger sibling, who's a toddler, they're marginally housed. They alternate between living on the streets and living in a shelter. They can only carry a small amount of stuff with them at a time, as you can imagine. And so they're really mindful of that because they have to transport all of their belongings with them. And they routinely do not have refrigeration. They don't have access to hygiene. They don't have access to privacy. And when you look at this child, you see widespread eczematous dermatitis, and you're also worried that they might be secondarily infected with staph. And you just look at them and they're scratching. And so this brings up so many things for me in terms of how we're going to help this patient. There's so much to think through. And I think a lot of us, when we see this, we get really overwhelmed. And this is a quote by someone here that really struck me, and I'll read it to you. So she said, "I diagnosed abdominal pain when the real problem was hunger. I have mislabeled the hopelessness of long-term unemployment as depression and the poverty that caused people to miss pills or miss appointments as non-compliance. My training had not prepared me for this ambush of social circumstances, and real life obstacles were having an enormous impact on my patients' lives, but I didn't have the skills or the resources for treating them. And so sometimes I just ignored that context." And I really love this. It's beautiful, it's very poignant, it's very real. And this is something that I've definitely felt and something that I encourage our trainees to reflect on as they take care of people. So you'll see me, the new terminology is social and structural drivers of health, but you'll see in a couple slides, I still have this deterministic language. This is a little bit of an old guard language, so I apologize for where it's not exactly up to date. But these are defined by the World Health Organization as the circumstances in which people are born, grow, live, work, and play. And as we all know, these are shaped by the way that our society distributes power and money and resources. And the big picture is that a lot of what influences our health is not what's happening in the exam room and not the prescription that you're giving to your patient, but all of the things that are happening in the context of their life. And I know that this is not new to you. And there are 5 realms that the CDC places these social drivers into: education and healthcare access, how our neighborhood and our built environment look, what is our social and community context, and economic stability. And so, of course, negative social and structural drivers of health, lack of access to these things, loneliness, poverty, lack of green space. And so we think about that a lot when we're taking care of our patients. I think another way to think of them is in terms of categories that either are just unmet social needs that are not traditionally areas that we think about in medicine. So that could be people who are experiencing homelessness or food insecurity, people who have specific legal issues, or maybe they're incarcerated, people who are experiencing violence in the home. And then separately, some really strong drivers that are actually factors that influence the way we connect and communicate. So language and education level, health literacy, norms, attitudes, bias, and discrimination. And I think it's helpful to parse this out because a lot of us can feel really hopeless when we think about this and powerless, but there are a lot of these things that we can chip away at. And so a key point is that for many of us, I finished med school 10 years ago. I don't feel like I really got a great sense of this in my training at that time. I know that it's a lot better now, but the traditional social history that we're taught does a really poor job of capturing some of the things that are happening in people's lives. And for that reason, a lot of us might see this as this impenetrable black box. We know it's happening, we understand it, but we don't really know what tools we have to work on it or what questions we can ask that are meaningful. And then layered on top of this, just defining a term, which I think is really important for this talk, is what we consider vulnerable populations are often people who are existing where there are multiple social drivers of health that are lacking all at once. And although I could read this list to you, I won't. But children, I think, are a very important group on this list. And I want to go over some of the reasons why that is. First and foremost, children, as we know, lack control over their social circumstances. They can't advocate for themselves. And in the United States, children are overrepresented among the poor. They're about a fifth of the US population, but closer to a third of poor individuals in this country. And the stats here just show you in terms of poor and low income and how that relates to the federal poverty threshold. The highest childhood poverty rates are both in the South and here in the West of the United States. And among these children who are classified as low income, a substantial proportion are experiencing housing insecurity, energy insecurity, and many, almost half, are receiving supplemental nutrition benefits. And again, another term, so I give this talk to dermatologists, and a lot of this is new, and I know that none of this is new for you, but I think it's really important just to at least anchor on this for a second, because there's actually some good data about adverse childhood experiences. So these are potentially traumatic events that occur in childhood, and we know that they occur along a spectrum over time and are linked to many negative health outcomes in terms of mental and physical health, as well as substance abuse. And they also affect people's earning potential and how far they progress in their education. There are countless examples of these, as figures from the CDC: physical and emotional abuse and neglect, having household members who are suffering from substance abuse or mental health issues, incarcerated family members witnessing violence and sexual abuse. And over time, these progressively lead to chronic health conditions, or at least are associated with them, and a low life potential. And so this concept that this can be the foundation of someone's life, one or more of these, and the way that that affects you is pervasive and carries on throughout your entire life cycle, I think is very humbling, and just helping me think of a lot of diseases are in some ways developmental diseases that are happening early in life that are altered by all of these factors, I think is very humbling. But at the same time, perhaps an opportunity if we can alleviate some of these toxic stressors in childhood to really make a difference. And I just flashed up a couple of things. Like I said, I didn't feel like I really understood this in medical school. And there's so many books that touch on these. There's a couple of things that really affected me a few years ago when I read them. And I think the bottom line was when I read about this, one of the points, for example, was about what fraction of people who get classified as obese or overweight have a history of trauma or ACEs. It's a really high percentage. And that's not to paint people with a broad brush or be deterministic, but just to say, it was very humbling to learn that a lot of the things that I think of as medical conditions actually have roots very early in life and in trauma. And I was kind of mad when I learned that, because I thought, how do I not know that? And indeed, about 60% of US adults have experienced at least one ACE. About 20% experience 4 or more. And in a survey, the majority of people will tell you, parents will say, I think my doctor should ask about this list of things. But this is the most recent survey. I've tried many times to find a replicate that's more recent, but this was from 8 years ago. Only 4% say that they ask about all of them. And so it's really hard to do this well, but we do know that if we address and prevent them, there are millions of cases of various diseases that we could identify, potentially prevent. And that all makes me wonder, what about skin diseases? Like I said, this is all very new in the House of Dermatology and not something that we've talked about a lot, and certainly not something that we're taught to ask about much in residency. So what I hope is educational for you is what data we have on the skin diseases in our pediatric patients that do have really strong social and structural drivers. I'll go over examples of 4 of them. This is where most of the evidence is. And again, this is not a clinical talk aimed at getting you to recognize these diseases and treat them. We could talk about that for an hour for each of these, but it's really aimed at trying to get a sense of what this is like for people in their real life. So eczema, so common. It's like probably 20% of what I do every day, maybe 30%, depending on the day. This is characterized by dry skin, a lot of itching, and it's really the itch that rashes. It's the defective skin barrier that causes itching that then causes people to have rashes from chronic scratching and rubbing. And this is a chronic disease, which is something that we try to address from visit 1. This is going to be around for a while. It's going to come and go. You have to manage it when it's flaring. You have to manage it when it's not flaring. It's really challenging. And we know, of course, that family history and personal history of other atopic disorders is very important, but not necessarily the whole picture. And multiple studies over the years have shown that eczema is more prevalent in places where people have a higher socioeconomic status. And that's that whole hygiene hypothesis, which a lot of us have heard about. But the severity of eczema does not necessarily follow that trend. And in fact, severe eczema and the spectrum of eczema has been associated with lower socioeconomic status across multiple studies, lower income, certain types of family structures, housing and education status. And that's what I want to get into as we think through this. So this was a very large study that was published a few years ago, 13,000 participants. And eczema was found more often in people who live below the federal poverty threshold in this US-based study. And there were certain family structures that really stood out. So single parent households, people who are living with non-biologic parents, people whose parents weren't married and didn't have an active co-parent, those were more likely to have eczema and have severe eczema. And I think this is really helpful, especially from a PEDS lens. Managing eczema is very expensive. It's very stressful and it's very burdensome. And we will often tell people, we'll give them medicines. Maybe we forget to give them enough tubes of medicine. And so they run out, and then that's stressful because their insurance won't bill them for another 25 days. But you're also telling them to go buy all these moisturizers. It's very expensive. It's a lot of stuff to carry around if you don't have stable housing. And what's been shown in the studies is that taking care of a kid who has eczema is more stressful than taking care of a kid who has insulin-dependent diabetes. And that's partly because not just these financial costs, but these families aren't sleeping, the kid's not sleeping, they're waking up the parent, everyone's miserable, no one can go to work. It's very disruptive. And in fact, not only is it more stressful, but the costs have been shown to be higher than taking care of a child who has asthma, even if that child was hospitalized in the last year for an asthma exacerbation. And so this is a really pervasive and big deal. And I'm going to show you some studies to kind of tell the story and illustrate the theme, not to get into the nitty-gritty of all of these studies. I mentioned this and I alluded to this before, but not only are certain family structures associated with having more severe eczema, but there are certain trends that have been identified in families of children with eczema. And they include moms who are at higher risk of filling medicines for psychiatric disorders, siblings who are at higher risk of getting an adjustment disorder diagnosis, and fathers who are more likely to fill pain medicines, for example. And the idea here is that the burden on the family is going to affect how you're managing the kid's eczema, and then vice versa. And so really thinking about that and figuring out how it's affecting people is really important. And so I try when I can to get a sense of that picture. Are you sleeping? Are they sleeping when we are seeing these patients? I'm so glad this study was done. This is a study that actually looked at ACEs specifically in children who have eczema in the United States. And they looked, it's interesting, they looked at it at 3 different points in time. They looked at them at around age 5, around age 9, and around age 15. And I know there's a lot of text on this slide, but the bottom line is at age 5 and 9, your ACE exposure was really important when it came to the likelihood that you were going to have severe eczema. That was not necessarily true at age 15. I presume, and I think it was hypothesized, that the older you are, the more likely you are to be able to advocate for yourself, help manage this yourself. The younger you are, you're really depending on your family, and the structures that are happening in your family are going to play a big role in what's going on with your skin. And so ACE exposures are definitely related to eczema, and children who have a greater number of ACEs have been shown to have a higher prevalence. This is another study that came out just a couple of years ago. They asked the question over the course of many years, do you have any issues getting medical care in the last year because you didn't have transportation? And they asked these of families of children with eczema. And they found that about almost 5%, 3% of people with eczema did report transport delayed care. And there were certain risk factors, which are not surprising risk factors. It had to do with Hispanic ethnicity. I don't think they looked at language, but I wonder if that was playing a role there, depending on the location of the study. Income, of course, being below the federal poverty threshold, and having no health insurance or having public health insurance were associated with transport delayed care. I'll put a pin in this because we're going to talk about telehealth a little bit later. Really glad this study was done too. This just came out a few years ago. This was a study based in North Carolina, published in 2020. And they looked specifically at Black and white race among children with eczema. And they found that there were various social factors that were likely to be true among the Black children in their study, including more likely to live in rented homes or be in lower income families or have caregivers with lower educational attainment. And those factors were each linked to worse severity of eczema. What I thought was really interesting about this study is, and it speaks to the structural racism, is when they looked at the Black children who were living in segregated communities compared to those who were living not in segregated communities or in lower residential segregation, the segregation played a huge role in the health of these children. Of course, we don't know cause and effect, but living in highly segregated communities made you 6.5 times more likely to be suffering from severe AD. And that was the association they found. Excuse me. Another thing, I have a lot of parents come in across the spectrum of socioeconomics and life challenges, and they'll talk about their concerns about treating eczema with topical steroids. And one of the things that we will often say is there are a lot of risks to not treating your eczema too, and really try to emphasize the safety of our approaches, but also talk about what are the harms that happen when people have unmanaged eczema. And that fits squarely into this talk, right? So for children with eczema, there are numerous negative quality of life impacts. Some of the medicines that we give people are sedating, try to give those at night, but some people are taking Benadryl in the morning and not realizing that that's affecting their school function. People are deprived from sleep because they're up, consciously or not, they're up scratching at night, and that's very disruptive for getting a good quality sleep. They're also really distractible because they're kind of antsy, they have ants in their pants, they're sitting there scratching in school, they're not able to focus. And we know that that can affect their performance. And in fact, it's been shown across multiple studies. This is a study published a couple of years ago in JAMA showing its association with learning disability diagnoses in children. And having eczema was associated with learning disability diagnosis, especially if it was severe. And then in addition to that, not just your ability to function in school, to have disability in learning, but what are the odds of you being able to complete your education? There have been studies also showing that. And so I talk to parents of all walks of life about what are the harms if we don't address this fully in terms of ADD and attention and sleep. And I think that's also really important to emphasize. So shifting a little bit in terms of some of the practical stuff. So I didn't put this on here, but Aquaphor and Vaseline are basically the same thing. And Vaseline is much cheaper. And Vaseline does not have some of the things in it that Aquaphor does that could cause irritation. So just use Vaseline. It's better on every way. This shows you, if you walk into Target, what's the price you're going to pay for some of these. And they're pretty similar ounce to ounce. These are all 16-ounce containers. Not that different. They're all great. That's all fine. There's some nitty gritties, but these are all fine. But what you may or may not know is that some of these are available at Costco and some of them are not. And if you look at the cost, it's a huge benefit to buying them in bulk if you can, if that's feasible for your life. And so I ask my patients, do you have a Costco membership? This could be very cost saving because there are no emollients or moisturizers that are covered by Medi-Cal or by SFHP. People always ask me to send it to the pharmacy, and we have to be very clear, like you can't get good moisturizers covered through your insurance. It's just not going to happen. So how can we get you the cheapest stuff available? That's eczema. We'll come back to it a little bit as we talk at the end. Psoriasis is a really common inflammatory skin disease that affects about 1 in 100 people. There are definitely genetic factors. Family history plays a huge role, but there's also a lot of environmental stressors. Obesity is associated with psoriasis pretty strongly, metabolic syndrome. This condition can affect the skin as well as the nails and the joints, which is really important to screen for. It's not just skin deep. And you can see kind of the panoply of how this manifests. It can be very stigmatizing. It's usually not as itchy as eczema, but it can be really hard to deal with. So a key concept with psoriasis is the relationship between our psychiatric health, our nervous system, and stress and disease. So this phenomenon of toxic stress is this idea that when we have a stress response, catecholamines and glucocorticoids are directly affecting our immune function. And we know, like people will tell you that their inflammatory diseases flare up with stress. I think that's really true. There have even been studies where you cut the nerve supply to parts of the skin and the psoriasis goes away. There's something there communicating the nervous system, the immune system, and the skin. And what has been shown, and I'm also really glad that they did this work in a couple of different studies in Croatia and Brazil with pretty good population sizes, was the correlation between certain ACE exposures and the likelihood of having psoriasis. So, and specifically in both studies, parental alcohol use and emotional abuse were found to be associated. there's a lot more work that could be done in this space. This is all we really have right now, but I think it's a start. And this idea that stress plays a role in how your skin is looking when you have psoriasis is really profound. There have been many studies, large cohort studies, showing that in people who do get psoriasis, they're more likely to have had a maternal figure who had lower educational attainment and a lower household income, which is probably related to that toxic stress piece. And this is a study that was published based on our San Francisco General Hospital population just a couple of years ago among people experiencing homelessness who were more likely to be experiencing psoriasis or seborrheic dermatitis flares. And some explanations for that included alcohol use, life stressors, and some of the lack of access to some of the care products that we'll talk about. And so having a really good patient-centered plan that meets someone where they're at then becomes really important, which we'll talk about. When you have psoriasis, as you may or may not know, putting on creams all the time, it's really hard. The creams, it's chronic, right? So the creams will make it go away for a bit, and then it'll come back, and then you put them on, it'll come back. Sometimes you can put some creams to try to keep it away. It's a lot of work. If you don't have access to personal hygiene facilities, that's really challenging. What's amazing is it's a pretty good time to have psoriasis because we have so many injectable biologics. We're really lucky here in California, and especially in San Francisco, because we are able to get these covered for almost everyone. It's really humbling to see what it's like in other places. But what this study showed, which is based in Ohio, is that if you were working poor, I classified as working poor status, you were less likely to be given a biologic prescription. Maybe your doctor didn't feel like it applied to you, or you were likely to get it covered, or that you could handle it. But that means that this person's really probably unnecessarily suffering. And on top of that, the separate studies show that if you had a lower socioeconomic status, you were less likely to have a response. And that was probably because of adherence. What's your ability to store this medicine in the refrigerator, arrange deliveries? Do you have a cell phone so that the pharmacy can call you? Do you have a safe place to put the medicine if you don't have a refrigerator? And so this kind of carries through your ability to manage your disease, what your doctor is willing to do for you, and how likely you are to respond. So at our county hospital, I run the peds clinic at the county hospital. I also do the HIV clinic there. We have a lot of things that we've worked on over the years to try to handle this better. So we work directly with our pharmacy as the SFG to get the coverage. And we feel pretty confident about who's going to get what covered, and we can tell them that in the visit. We store our medicines in the refrigerator. So people who don't have access because they're experiencing homelessness or housing insecurity, they can just come every 2 weeks, every 4 weeks, every 3 months, whatever it is. Just say, hey, I'm here. They don't need to visit. The nurse can just put the medicine in, send them on their way. They can come see us every so often. It really works. I think it's really helpful. And then we have biologics that only need to be injected every 12 weeks, which is extremely helpful for someone. This has also been a switch in the HIV medicine realm of how to get things that are easier for people to adhere to. Light boxes are very commonly used in dermatology, less so than maybe 20 years ago because we have so many other options. But phototherapy is a really useful tool. It's also doesn't suppress your immune system, doesn't carry the risk of medication side effects, super useful. The access, though, is really challenging. And even though Medicare and Medicaid cover phototherapy very well, a lot of private dermatology clinics just don't accept those forms of insurance for any patient. And so even if they could treat your patient, they might not be willing to because they don't accept their insurance at baseline. And so there are tools that we use. You don't have to know this, but I think it's helpful for you to know. There are tools that exist to help us find places for people all over Northern California and Central California, both through our derm societies and through the Psoriasis Foundation. They'll have to call the clinic and ask for help, but there are ways that we can get these patients care. And I just put that in there mostly for a derm audience, but also because I think it's useful to know that there are other options. This is very inconvenient though. You have to go 3 times a week and it's like 5 minutes in the box and then you leave. It takes more time to get there, far more time to get there than the treatment takes. This is not something good for someone with transportation issues. Flash this up, but I should delete the T-gel thing because much to my chagrin, T-gel is not being actively manufactured anymore. It was one of my favorite things. It's like coal tar that really soothes the scalp. But all this to say, most of our management of psoriasis is through prescriptions, but there are some things over the counter that can help, including coal tar ointment, coal tar shampoo, and things like salicylic acid that can really help break down scale, like in the scalp, for example. And the key point of this is that these are really expensive. So sometimes someone might come to me with a care plan, but not think, well, is someone really going to spend $50 a month on shampoo? And are they going to be able to cart it around? I mean, I think that in that case, an injection really would be better. There's so much I could say about hidradenitis. A show of hands, people seen this? So not everyone, which I think is really helpful. This is one of the hardest diseases. If you ask me what's the most common heart disease, I can think of a lot of really hard diseases, but this is one of the most common, really hard things that we see. And HS, which we'll call it throughout the rest of the talk, is a chronic inflammatory condition affecting the apocrine gland-bearing skin areas like the axilla, the groin, the chest, especially the inframammary chest, and the buttocks. And these patients will come in often with small papules that evolve into nodules, that evolve into draining lesions, and then they tunnel together and they form sinus tracts under the skin. And despite antibiotics and all sorts of management tips and tricks you might try, by the time it gets to the point where it's tunneled, this is almost impossible to manage without really heavy duty medicine and sometimes surgery. And we know from the literature that family history, obesity, smoking, and race are really predictive of this condition. And there's a lot being done, including by colleagues here at UCSF, to figure out why, especially with the racial and the obesity piece. Sorry about my cough. Let these stats sink in while I drink my coffee. A lot of people will come in with this after being misdiagnosed for years. On average, people will go in at least 5 times before they get the right diagnosis. The average delay is 10 years, and these patients come into the emergency room all the time, all the time. If you ask any of our derm residents, you know, who our frequent flyer is, which is kind of a derogatory term, right? Because there's so many things that go into that, but who's often coming in? Who do they know really well? Who have they seen multiple times in the hospital? It's people with HS. It's really, really tricky. And these patients are 17 times more likely to be obese than unaffected people, which is really profound. This is a study from the Netherlands, which was focused on socioeconomic status in HS. And what you see here in the figure is that unlike what's the case for nevi and skin cancer on the right, HS and psoriasis have really high levels of high levels of low socioeconomic status in the people who are affected. And this is important. And I think it's probably cause and effect, and it has a lot to do with toxic stress and also how hard it is to manage this condition. This has been shown in another study in the United States, so not just in Europe. Patients with HS were almost twice as likely as unaffected patients to have low socioeconomic status. And that was true even if you modified for all of the other factors that you might think might be confounding that. Now, I don't even know if I've done a good enough job painting the picture, but if you've seen patients with this, they're really suffering. They have stinky, draining nodules in very sensitive places. They're not able to focus in school. It's really stigmatizing. Makes it really hard for you to have a healthy sex life. It makes it hard for you to want to participate in society. It's this really vicious cycle where it impairs your ability to work and play and go to school. And because of that, there have been various studies that have shown its impact on income and work loss and so many indirect costs. And so, although I don't expect any of you to manage this primarily, I think it's helpful to know that there are some really good tips and tricks for how to get these people care more effectively. I really liked this review that was done a few years ago, and I just wanted to highlight a couple key points from it. I think telederm can play a really big role here. We do a ton of e-consults, both here and at the general, and we see a lot of new HS. And we can say, this looks like HS. This looks like the severity of HS. This is when I want them to come in. You can start these in the meantime. Make sure you give them a 90-day supply so that they're not having to go back and forth to the pharmacy if we want them to be on antibiotics for 3 months. Just small things that can make such a big difference. These patients will go through clothes quickly, especially if they don't have a way to launder their clothes. And so affordable clothing options, and then talking about like going to Costco if you have a membership, and then purchasing things in bulk that can be moisture wicking, or big sanitary napkins instead of some of the maybe more formal medical dressings that you would think about. And then biker shorts, which can be worn over the legs to secure all of these things and also reduce friction and irritation. Friction and irritation play a huge role in perpetuating this. I mentioned that these patients are 17 times more likely to be obese. They are often still undernourished though. And so they need help with getting access to SNAP benefits. They need help with mental health comorbidities. It's really important to invest time when we're caring for these patients and really methodical stepwise treatment plans. Here's what you do if this happens to try to prevent admission. So much more we could say about HS, but alas. I won't say a lot about acne because everyone has acne, right? That's the other most common thing I do. And I love it. Everyone gets acne, no matter what your background. The severity is often related to family history and hormone status. But what we do know is that if you have acne and you're suffering from poverty, if you don't have access to health insurance, if you can't access so many of these over-the-counter things that we recommend for acne, you're going to have worse acne, right? And that can lead to scarring. And the most effective treatment we have for acne, which we do all day long, is isotretinoin, or also known as Accutane. And this, as you might know, poses potential major administrative burdens for people. There is a monthly confirmation system that you have to do when someone's on Accutane. They have to be able to come into your clinic. They have to have access to Zoom if you're going to do a telehealth visit. What if their parent doesn't speak English? Trying to do Zoom across a language barrier can be really tricky, especially if there are delays in getting into the exam room. It's really hard. And we'll talk a little bit more about telehealth, but I think this can be really humbling. We will often tell people to go to the store and buy over-the-counter products. And I flash this up for the residents, but also for any of you who are telling your patients to buy these things. CeraVe AM facial or CeraVe acne foaming cleanser has benzoyl peroxide in it. So does Neutrogena Clear Pore, but the CeraVe is twice as expensive. Now, I love CeraVe. We recommend it all the time. It's very hypoallergenic. It's one of the most hypoallergenic commonly available things, but it is helpful to know that the same thing or almost the same thing is twice as much, because there's a difference that you can make if you're looking at the price of these things before you send them to the pharmacy. Same thing is true for Panoxyl, which is another form of benzoyl peroxide, one of which I would use on the face and a stronger percentage of which I would use on the back. These things are not all the same costs. And what's important to know is that patients who have Medi-Cal can get almost all of these covered, which you may or may not know. So I think it's worth trying to send that prescription if you're worried about cost and at least try to get it covered. I want to talk about telehealth. There was a conventional wisdom that for many years that there is this digital divide in society where not everyone was accessing technology and using the internet in the same way. And that was shown to vary across race, ethnicity, socioeconomic background. And there are a lot of factors that go into play, including language and financial barriers and health literacy. And in 2021, 15% of people in the US did not own a smartphone. As a number goes down and down over time. But the patients that were most likely to be affected by some of these lack of access issues were people who were living in rural areas and people of lower socioeconomic status. And yet, there's all these barriers to people coming in person. Childcare, do they have anyone to watch their kid or kiddos? Does work allow for them to take off time for appointments? Do they have access to transportation? So promising potentially, but all this data to show that the patients that we might want to help the most might not be able to get help from this. So should we try? And a lot of defeated senses. And then of course the pandemic happened and then everyone switched to telehealth and all of our visits were telehealth. And we really found out which meetings could actually be emails and Zoom meetings. And this was very illustrative of what we could actually do. And I appreciate this study from UMass, which showed what happened. And specifically what they showed. So you see in-person clinic visits in blue, telemedicine visits in gray. And the big picture here was that when we switched to televisits at this site in UMass, there were significantly lower no-show rates. And some of the people that traditionally have been categorized as maybe a lot less likely to access telehealth actually really was helpful for them. And that makes a lot of sense if you think about the factors happening in people's lives. There was no difference in the race and ethnic background of the people seen. Everyone wanted to access things in this way. And in fact, people with Medicaid were able to be seen at a higher percentage than they were. Their no-show rates went down. And so in PEDSTERM, we increasingly use this for certain scenarios. I mentioned we do a lot of e-consults, which kind of fits into this realm, right? It's really helpful for people who live far away. I will often look at the distance traveled by someone when I'm thinking about when to bring them back and how to bring them back. And I do almost all isotretinoin and propranolol for infantile hemangiomas follow-up is remote, if I can. So especially for Accutane, almost all of my patients on Accutane or isotretinoin are following up by video visit after that first encounter, which is hugely beneficial because they can be seen after school. It takes 5 minutes. they're not transporting, they don't have to miss school. For a hemangioma patient who lives very far away, I will also do follow-up that way. I would love to focus a lot on this, but I think I'll just illustrate a couple key points. As I mentioned, health literacy and some practical tips. I think this message is, I think you appreciate this message, which is, we're only as good as our words. And I think a lot in clinic about how we're talking to people. Only 12% of US adults in studies have found to be, quote, proficient in terms of health literacy. And that's a really big predictor of health status. And so when we're talking to people, we need to keep in mind that having a lower health literacy and how we communicate across that divide is associated with a lot of negative health outcomes. And there's a big discrepancy between the things that we might think are helpful in our patient education materials and the things that people actually are able to take in. And the core message here is that these materials ideally should be at a 6th to 8th grade reading level. And a lot of us have spent so much time learning sophisticated language that we have to unlearn that in order to talk to people. And this is something that I see a lot in clinic, and I try to work with my trainees on, and I try to work on in myself. I flashed up a couple of examples here. This is a kind of a standard spiel that we might give someone who's coming for the first time. Your child has atopic dermatitis. This is an overactive immune system that's causing these itchy plaques. And there's no cure, but we can control it with topicals. And what I hear now when I see that, now that I've been thinking about it for longer, is, do we really need to say atopic dermatitis? Do we really need to say immune system? Do we really, what's a plaque? Like, no one knows. And what does topical mean? As opposed to this, which is your child has an itchy rash called eczema. It makes the skin red and scaly and dry. We can't make it go away and stay away, but we have some creams that can help. And similarly, this is, and the one on the right, much easier to read, right? Similarly, I'll put these two spiels up because I don't have to go through them, but one of the things that comes up a lot for me in clinic is the idea of systemic therapy and monitoring labs. And I think a lot of that language is confusing too. And so I try really hard when we can to simplify that and explain what we mean by those terms. If you're not aware, the Society of Pediatric Dermatology has available to everyone these handouts, which are really helpful, and they are all at the right reading level for the general population. This is very simple, but this is something I do all the time. Most of my patients at the county do not speak English, and they have a toddler that I'm recommending a pretty complicated care plan for. And it's really hard to know how best to communicate, because even if you feel really confident in your interpreter, or even if you speak some Spanish yourself, how are they going to remember what you tell them? Which is true for every patient that you see. How are they going to remember 80% of the stuff that they forget when they walk out the door? So if you don't do this already, I like to draw a stick figure on a piece of paper and point with an arrow and write out the full generic name of the medicine and write out the number 2 or 1 and then how many times per day, and just point to the part of the body, because of course each part of the body might need a different type of medicine, and explain to them, like, this is what you do when it's flaring, this is what you do to maintain it. I think it's gonna be really helpful. And then tell them to take a picture of it with your phone so you don't lose it in case you're on the go and can't keep track of all this paper. So the last section I want to talk about is screening. And we know from all the background that I gave you that having a sense of this and identifying it and addressing it can have profound impacts on people's lives. And as many of you know, the American Academy of Pediatrics therefore strongly recommends that pediatricians screen for ACEs, that they screen for social drivers of health, that they take into this framework that's very broad and big picture. And there are, of course, some specific guidelines in place for this. But as I mentioned to you before, a lot of people don't screen for them. I think that there are aspects of it that feel overwhelming. It's hard to know how to fit in the questions. People wonder, are the questions going to be offensive? And only about 1 in 5 clinicians routinely screen for these needs. And a lot of people say it's because I don't feel like I can do anything about it if I find it. Like, why would I ask something that I can't fix? That makes us feel really powerless. And yet we might say we do need to understand that this is happening in people's lives. So why don't we screen? We lack the time, we lack the knowledge. Maybe our clinic support structure just feels too difficult and we need more support. Again, you think, well, I could ask about something and identify it, but what do I do if they tell me that they're food insecure? How do I help? We don't have a social worker in our clinic. Lots of factors go into play. And the last one I think is really important, which is someone's economic background, your own economic background, and how that influences what you see. And there have been studies that show that physicians will give patients of lower socioeconomic status consistently give them more negative ratings on personality characteristics that really don't have much to do with education or anything at all that relates to income, intelligence, the likelihood of doing what you ask them to do, the likelihood of having significant career demands, how likely you are to do a therapy. And related to this, this was a separate study out of Florida, which showed that the racial and ethnic composition of the person that was surveyed was one of the only things that was linked to someone believing that the benefits of collecting this information from someone and getting to know these factors of their lives were outweighing the risks of doing it. So again, your personal background and how it affects how likely you are, at least in the studies, to think that this stuff matters. And kind of bringing it all around, I really like these two terms, and I think that this fits in really nicely to what we're just saying, which is this concept of individual empathy, which we all kind of know that the definition of, is a little distinct from the concept of social empathy, which is how we understand people by seeing them in the context of their whole situation and how that affects them, how they're affected by disparities. And structural humility, and I have to like bold and underline this for myself because it's one of the hardest things for me as a relatively impatient person, is the posture of collaborating with community leaders and other disciplines with a sense for the patients, for the slow speed of structural change. It's like the slow speed of structural change. It's really hard for me to accept sometimes how many obstacles are in the way and how powerless that makes me feel. So, I know that pediatricians screen for these in their clinics. The question I ask myself is, should dermatologists be doing that? And a lot of people have wondered, you publish editorials on this and people will say, does this really apply? Like, do people care? This is not why people read derm journals. But I definitely think that if we're caring for children in particular, we should screen for things that might interfere with our ability to make a good plan. And that's kind of where this starts. And that includes things like your housing status, your parents' educational attainment and their health literacy, how much trust there is and whether there's any barriers there, and overall levels of household stress. And this is a study that just got published by my really close friend and colleague, Dr. Chang, at the General last year. And I was in JAMA, and they basically took a cohort of patients and they asked them, how do you feel about these questions being asked of you? Which I think is really important. Like you can have this sophisticated understanding, you think, of all these factors that are playing in, and I'm going to ask about them all and I'm going to spend extra time. How does that make someone feel? And so they ask, do you think it's appropriate for me to ask you these questions? And would you be comfortable if I included your answers in your medical record? Which I think is really important to this whole concept. And the majority of people consented to participate, and of them, most of them completed both measures. And 86% of the patients said they thought it was very or somewhat appropriate to be asked. A smaller percentage wanted it documented. And I think that's okay. You can still make a really sophisticated care plan without necessarily putting all of someone's vulnerable details in the chart. And their comfort level was associated with how much help they wanted. So they were much more likely to engage and want this if they felt like they needed help. And some of the key themes that came out of this qualitative research were that the rapport between the provider and the patient is really helpful. If you do this on the first visit, it might not be that effective, but if you're seeing them for the third or fourth time, people are much more likely to open up. It mattered a lot whether people trusted the general hospital. Some people have really bad experiences there. Some people have great experiences there. That institutional trust and rapport was huge. People want to know, why are you asking me this? Like, what do you mean, do I have a shower? What do you mean, do I have a bath? Like, putting it into context was very important to these patients. They wanted to be told, I'm asking you this because it will affect whether we do A or B. And just keeping really straight and to the point. And then they also said, if my provider is going to ask about this, I want them to be able to help. And that is humbling and important. And so I would pose, with everything that we kept in mind, with the patient that we started with, who's marginally housed with uncontrolled eczema and not a lot of access to refrigeration or privacy, these questions, I think, are a good place for us to start when we're thinking about people with skin disease and what we might want to ask. And they include, do you have access to a bathtub or shower? Do you have access to a refrigerator? Do you have access to laundry? This comes up a lot with people who have scabies or body lice. do you have a private place to put on all of these creams that I'm giving you? Because, you know, they require people to shower and get naked and put creams on. It's very vulnerable. Do you need help with transportation? And would you like any recommendations for wound dressings? So it's a start. I think it's relatively simple. You can use your judgment when you're seeing someone, and I think we can do this in a really non-judgmental way, and just make sure that if you're recommending something, it can actually be done. So finally, we started thinking about this a lot in the context of caring for people experiencing homelessness, and in the setting of writing a review and an editorial on that, we were asked, well, does this really apply to derm? And if so, what are you doing to make this better? And we were pretty inspired by some of the reviewers' comments to create a curriculum at UCSF for our derm residents. So we established this 4 years ago. We just completed our first 3-year cycle. Right now, it's pretty traditional, like lectures and grand rounds and journal clubs, and hopefully more in the future, more small groups. In the setting of that, we also established this concept of a health equity chief. And these are residents that we have are particularly interested in this topic and want to drive this forward and work with us. And this has been really fruitful. We've done a lot more community engagement as a result of these roles and these titles that we've given to some of our really interested trainees. We work really hard to mentor people who are interested in this and specifically want to go out and work with underserved patients. And then we have patient navigators and social workers, relationships that we really didn't have before that we're trying to be better at cultivating. So children are a vulnerable population. I think a lot of these social drivers and adverse childhood experiences do affect skin disease. And even like when I started doing a lot of research for this talk and for this curriculum, I was pretty impressed by the amount that was already known and also pretty humbled by how much work there is left to do. I hope that you'll think about cost and literacy and some of these key screening questions when you're taking care of your patients with these conditions, and then consider screening when relevant and in some of the ways we talked about in your clinic. And I'm really grateful to be here and appreciate your attention. And it's really special. Thank you.
Great.
I had a question. I know you were talking about the how the providers.
Yes. In that study, it followed racial and ethnic lines, and it said a person of racial and ethnic backgrounds that were not the majority, and that was in Florida, were more likely to think that screening was important. And that's probably confounded. It's probably, I mean, it's not race that's the cause, right? It's the factors that are confounded and associated with that life experience and how it kind of opens you up to what might be going on that you're not seeing like directly in front of you. Of course.
I had a question, and I don't know, you might not know the answer to it. I definitely don't know the answer to this, but I was struck by what you showed of the prices of some of the over-the-counter being very expensive. And then you mentioned, and I don't remember exactly the details, but that certain over-the-counter creams were actually, for certain indications, eligible for health care insurance reimbursement, and others were. And it's struck me because I actually just discharged a patient not too long ago from our ICU who needed Tums. First, I had hypocalcemia, and of course, a 7-year-old only wants the special flavored Tums. And I was like, that's an expensive bottle if you need to take this many of them every day for a family whose household protection. What goes into these decisions of what over-the-counter drugs can you actually get reimbursed for and which ones not? And what, any idea what additives you can?
Yeah, so the good news is that for eczema, pretty much the only thing that people are having to pay for out of pocket is moisturizer. And in those cases, I will tell people about plain Vaseline as probably the cheapest thing that they can do, but they still have to pay for it. And of course, it can be purchased in large quantities. But is that feasible? Most typical acne medicines that you think of as being over the counter are covered by Medi-Cal with a low copay. And so it's worth trying. A lot of private plans don't cover them as well as Medi-Cal does. And so a lot of people will have the experience of, oh, that's not going to get covered. I'll just tell you, go to Target or go to Walgreens and pick it up. But in reality, like benzoyl peroxide, salicylic acid, clindamycin are covered pretty well, at least by SFHP and Medi-Cal. And then for psoriasis, most of our stuff is prescription. So there's a handful of things that we tell people to go out and buy, but I think we can rely for the most part on insurance for people of really low income. And then for the patient, I didn't ever really circle back to it because a lot of the themes we touched on, but for the patient that I started with, who has widespread and doesn't have housing, I think that's the kind of patient that you get Dupixent for. I can't believe I didn't say the word Dupixent in this talk. Oh my gosh. That's my favorite medicine. And it's life-changing. And that's gonna clear them right up, and antibiotics because they're infected with staph. But that might be a situation where I think I'm not gonna waste this person's time. Maybe they do have a few dollar copay for their topicals. Maybe their insurance doesn't want to cover enough clobetasol. I'm gonna go straight to where the money is. I'm not gonna like pass go. I'm just gonna go straight to Dupixent. And I think that is one of the ways that you factor in someone's life circumstances, even though it might think, why would I think of an expensive medicine? But actually, that's going to be the most direct way to get them healed. Hi.
Sorry, I have another question. I like that you pointed out that we're.
Yes. I don't know that that's been studied. I would guess that if it were to be studied anywhere, it would be studied for eczema and psoriasis. I haven't seen that pop up, but there are a lot of, if you go to our big meetings, there's a lot of talks about stress and its role in skin disease. Anecdotally, I can tell you it makes a big difference when someone's life circumstances become calmer and more manageable. There are aspects of that I feel like might be hard to study, but also aspects that might not be. So I don't know.
And also access.
Exactly. Yeah.
So,
yeah, that's definitely true.
Questions, thank you very much.
Guys.